Good morning, everyone. Thank you for joining the KSELS KAROS virtual conference, the first virtual conference. This is the first session. It's the KSELS KAROS and EAES joint symposiums. My name is Joong-Min from Chung-Ang University, Korea, and I am a chair of these sessions with Professor Andrea Pietrabissa from University of Pavia, Italy. In this session, we have four speakers. Four speakers will talk to us about the bariatric and metabolic surgeries. And after our lectures, we'll have a Q&A time with speakers using the question button on the right side of the screen. And the Professor Pietrabissa will introduce the first two speakers from EAES, and I will introduce the last two from Korea. And now, as the Professor Pietrabissa, please start the introduction.
Yes. Thank you, Professor Park. It is a real pleasure. I'm honored on behalf of EAES, of which I'm the current president, to be here today. It's a privilege. We have had a very long and a strong friendship between EAES and KSELS, and it's a pity that this year we cannot shake our hands in person in Korea as usual, but we have to adapt to the challenges of these hard times. As Professor Park was mentioning before, this session is about bariatric surgery, and we have some quite interesting topics that will be covered by each one of the four speakers provided. And the first speaker to introduce this session is Professor Nicole Bouvy. Nicole is Professor of Surgery at Maastricht University in the Netherlands. She's a general surgeon with a dedicated interest into bariatric surgery, and will present a topic on endoluminal options to treat obesity as an option for revision surgery after weight regain. So please, Nicole.
And the next speaker.
So you want me to
introduce as well? Okay. We introduce all four speakers.
All of them, okay, good. Yeah. So after Nicole, we'll have Professor Di Lorenzo. Nicola is a professor of surgery in Rome, and he will present our attendees the 2020 EAES guidelines on bariatric surgery, an effort that we have done within our association to provide our members these new guidelines.
And after that, the third speaker is Kyung. This is my friend from Hanyang University in Korea, and he will give us a lecture on the animal experience for metabolic and bariatric surgery. And lastly, the Joong-Min from Hallym University is the chief of the KSELS, as the Korean. He will present a lecture about the hot topic in bariatric surgery research. That's all.
Mr. Chairman, ladies and gentlemen, my name is Nicole Bouvy, and I'm a professor of surgery in Maastricht University Hospital in the Netherlands, in Europe. Thank you for inviting me in this session on your virtual Congress of the Korean Society of Endoscopic and Laparoscopic Surgeons. I'd like to share with you what is known about endoluminal options to treat obesity. These are my disclosures, and as you can see, some of the companies we did research on endoluminal procedures to treat obesity, so they are listed here. As you all know, there's an increasing problem with overweight in our society, and more than 10% of our world population suffers from obesity with a BMI above 30. As you can see in more detail, Asia is quite okay. In Korea, it's not really a problem, but for example, in Malaysia, Borneo, and Papua New Guinea, there's a problem. In Saudi Arabia is a real big problem. More than 40% of the people suffer from a BMI above 30, and of course also in the US. Last year, together with a lot of societies, we stated in some guidelines some important facts about bariatric surgery. What was stated is that the laparoscopic gastric bypass, a sleeve and a band surgery can realize in between 45 and 65 excess weight loss after 1 year. Also, it was stated that laparoscopic procedures are associated with some morbidity and even mortality. And the success rate of endoluminal procedures was defined as more than 30% excess weight loss after 1 year. You can read this in surgical endoscopy of this year. So if we have such a successful surgery for people with morbid obesity, why think of new procedures? Well, the surgical knife obviously has two phases. It can realize excellent cure, and in this case, excellent weight loss, but it can also be compared with dreadful complications. And in case of bariatric surgery, we see an anastomotic leakage rate of 1 to 5%. We see de novo GERD after sleeve resection in at least 20% of the people. A few years after surgery, people can suffer from both internal and incisional herniation. The reported rate of internal herniations like Peterson's hernia is in between 2 to 16%, and incisional hernia from the laparoscopy wounds can appear in at least 10% of the people within 10 years. Also, we see adhesion formation in 10% of the patients that need a re-operation within 10 years after surgery. So can we avoid these complications by treating persons in an endoluminal way? That's what I want to discuss with you. And what we have as treatment options for endoluminal ways to treat obesity are the gastric balloons. We have gastric devices. There are endoluminal devices which are placed in the duodenum. Of course, these are temporary, and we have the more structural endogastric plications. So first, the balloons. There are all kinds of brands of balloons, and they all give more or less the same weight loss. What we can see is that the weight loss during the intervention is quite good. So we see about 16% excess weight loss after the removal of the balloon after 6 months, and we see total body weight loss of more than 5%. So quite good results, but there are also safety complications if we have a balloon placed. So we have seen even that, gastric or intestinal perforations and migrations. And what's probably the most weak point of these gastric balloons is that it can cause really nausea and abdominal pain in a lot of a great number of the patients who have these balloons in situ. There are interesting new kinds of balloons. For example, this balloon can be swallowed. without endoscopic intervention and has a self-degradable way of losing in the body, so that no endoscopy has to be accompanied by placement or retraction of this balloon. It's called the ellipse balloon, and it's placed now in Europe in many of the cases when a balloon is needed. So what about the gastric devices? We have the full sense device. This is a device which is partly a stent in the distal esophagus and which stretches the cardia of the stomach. The first results that were reported from this company in Michigan are really very promising, and showed so much weight loss that the device had to be removed. But we haven't seen a lot of this device lately, so I do not know if this is really an option, but it could be placed in a very quick manner. Of course also removed in a quick manner. Then we have the Aspire Assist. That's more or less a percutaneous placed gastrostomy catheter, as you can see here. As far as we know in literature, there are no serious adverse events. The duration of the intervention can be more than 1 year, and it's quite efficient. The excess weight lost in 1 year is 31%. And how does it work? After a meal, you really aspire the content of the stomach, and then people can eat more. So this is again some details about the full sense device. As I said, it can be placed very fast in 12 minutes, and the weight loss is enormous. But we do not know if there are still studies running on this device. So what's the hypothesis of the working mechanism of this stretching of the cardia? If you stretch the cardia, there can be a positive impulse to the satiety center in the brain, and this gives a negative feedback to the enteroendocrine cells. And then ghrelin is negatively influenced, and that's also what you can see in a lot of these procedures. So if you have less ghrelin, you will have less hunger feelings, and if you have less hunger feelings, you eat less and you will lose weight. If you have more okay, for the endoluminal gastric plication devices, there are mainly two that are very interesting and now in a large amount in the market, and those are the Apollo overstitch procedure and the POSE procedure. Both work with plication in the stomach and create more or less endoluminal sleeve. The devices are a bit different, with running sutures in the overstitch procedure and with interrupted plications in the POSE procedure. I will go over these procedures in the next slides. So, as for the overstitch procedure concerned, if you look in literature, there are minor safety complications, no serious adverse events in this procedure. The procedure takes about 1 hour and makes an endoluminal sleeve. If you look at the efficacy, there's quite a promising total body weight loss of 17% with a follow-up more than 18 months. big concern of those endoluminal procedures is the durability of the stitches, but in 1 to 2 year follow-up studies, this seems to be still quite okay. Then we have the post-procedure of USGI medical, which gives more or less the same results. It works a bit different, not a running suture, but these interrupted plications, about 9 in the fundus and 3 directly before the pyloric muscle. And these procedures, they change sometimes a bit of the location where the plications are placed. Also, no real safety problems with this device, and these plications can stay for life. The efficacy on total body loss is a bit less than the overstitch procedure, but also quite good with 1 year follow-up. This is a very good performed trial, sham-controlled, in which a lot of patients were included, and they were compared with sham plications, no plications, but endoscopy, and it shows a very good result. There are some other devices on the market, and we are exploring the efficacy of these procedures. This is one of them, the BioSense device. Worldwide, 60 patients were operated with the device, and the good thing is that the staplers were fixed with the plications were fixed with staplers, so really solid. But unfortunately, this company broke down and is not yet available on the market anymore. But the idea is quite good, and the weight loss was also quite good. We did a laparoscopic sleeve resection on one of the patients after 1.5 years. So this is the sleeve, and what you see here is the plications, so really solid adhesions which stay in the body for more than 1.5 years. And if you see this, it's so solid that you can expect them to stay there for the rest of your life. So really a reduction of the volume of the stomach. So now I want to discuss with you the endoluminal duodenal devices. So there is one still actively in the market, and that's the endobarrier sleeve. It's a sleeve made out of Teflon with a self-expandable stent on the beginning, and the self-expandable stent is placed directly after the pyloric muscle. And then, as you can imagine, all the food goes through the sleeve, and after 60 centimeters, the juices of the liver and the pancreas mix with the food, and absorption can take place. The Valentix device was more or less the same idea. It was only a bigger device, 1 meter, and it started directly after the lower esophageal sphincter. It could not be placed fully endoluminally, so it also needed laparoscopic assist, and we haven't heard anything of this device the last years. What's rather new on the market is the duodenal mucosal resurfacing device. It makes a kind of burn wound in the duodenum and is especially good for people who suffer from a combination of diabetes and overweight. So I will go over these devices in the next slides. So as the endobarrier procedure concerned, it can be performed under conscious sedation, guided by both endoscopy and fluoroscopy. So especially you need to see the guide wire passing in the duodenum and the first duodenum, and with the help of X-ray you must see that the anchor is placed really directly after the pyloric muscle and fully explored. You can leave this device in for in between 3 to 12 months, and the excess weight loss is about 20 to 25%. It's a temporary device. After 6 to 12 months you really have to remove it because there's overgrowth of granulation tissue over the anchor. So there are 5 big randomized controlled trials conducted. Well, big. The largest was 73 patients compared to diet. So the included patients, most of them had a combination of overweight and diabetes, and there was a positive effect on overweight and diabetes, and people could reduce their medication for diabetes after this endobarrier device. In total, there are 38 studies reported in literature with quite a lot of adverse events, from which 3.7% were really severe. And the big FDA trial, which started in the US, had to be stopped due to hepatic abscesses. There was also seen one esophageal perforation, bleeding and obstruction. Most likely all these events were caused by the anchor. At the moment, there is a new FDA trial running in the US, and this device is commercially available in Brazil, Chile, Germany, UK, and the Middle East. More than 4,000 procedures are conducted, so quite a lot of experience with this device worldwide. Then we have the duodenal mucosal resurfacing system. So this is a nice pilot study and a proof of principle, which already showed quite good results on the cure of diabetes in these patients. So the overall HbA1c decreased from 9.5 to 8.3 after this procedure. The durability is a bit under discussion. It's not clear what really happens in the mucosa and serosa of the duodenum. And further studies are running. This year in gut, a larger study was published and really showed also promising results of this procedure. So in conclusion, if we take all these procedures into account, the gastric balloons can help to give instant weight loss, can stay in for half a year, but of course it's a totally reversible procedure, and if nothing's changed in the way of living of these patients, they will gain weight again. The pose and the overstitch procedures are the most promising procedures as for the gastric plication, and they can cause structural weight loss. The follow-up is quite good at the moment, and it seems that the weight loss is quite structural in a great percentage of the patients. The endobarrier is a temporary and relatively safe device with in experienced hands, of course with liver abscesses and bleeding, and can give mainly effect on weight loss and diabetes control. Long follow-up shows that this is temporary effect, and that during the years of follow-up, people gain weight again and start needing more diabetes medicine. For weight loss, perhaps the stenting with the full sense device, this was the device that stretches the cardia, is probably most effective, but we do not yet know if this full sense will really go to the market in short time. And then if you have people who mainly suffer for diabetes control, perhaps the most safe, fast and effective manner can be the duodenal mucosal resurfacing device. And the longer term results of this device are still to be awaited. Okay, thank you for your attention. And I'd like to have your questions and try to answer them. Thank you.
And starting with our issue, with our topic, nothing like bariatric surgery needs standardization, because the fantasy of bariatric surgeons is very, very, very strong, so that we need to find out a way to put together the different procedures which have been, let's say, invented or created, and to create a standard. The best way to create a standard is for sure to issue guidelines. We know very well the first guidelines by NIH issued in 1991, still valid and still used all over the world. Then, after the advent of laparoscopy, EAES in 2004 and SAGES in 2008 prepared their own guidelines. The one we discuss about are the one of the 2004. Then the European interdisciplinary guidelines were issued, and then we must say that all the national society, almost all, prepared their own guidelines. So they were mainly based on expert opinion, which is not the method we followed and we will explain to you. This is the example of what happened in Italy, for example, just to let you know one of the many, many guidelines issued by national society. And this is the method we followed up. You see that we prepared the update of the European guidelines issued on surgical endoscopy in 2005, used the Delphi methodology, multidisciplinary and multi-societies approach, using the grade and agree with the review of the literature, and the use of this tandem, which I will explain you later. This is the coordination group, mainly Gianfranco Slick and myself, our two juniors, Francesco Carrano and Angelo Iossa, and the methodologists, which are coming from the research committee of EAES, Stavros Antonio, Nader Francis, the chairman, and Ferdinando Gresta. And this is the coordination group at work. You know that when you work together for long, you also need to create a good atmosphere among the people, and this has been a very good opportunity in Rome. By definition, treating metabolic and bariatric patients need a multidisciplinary approach. And this is why we decided to have a multi-societies coordination and involving other specialists from other specialists from other specialties. And the team involved, apart from the EAES surgical group, also the IFSO-EC European chapter, the European Association for Study of Obesity, EASO, many different specialists, and the European Society for Operative Care of the Obese Patients, mainly based on anesthesiologists. Here, in a different way, you see how the group was composed of. You see, in the authors of the final papers, we listed all the juniors because we thought it was a way to recognize their work, which has been really important and fundamental for the success we achieved. And this is the group in one of the meetings. You see how many people, happy people together. We follow the grade and the agree to rules, which are very strict, very complex to follow, and without a good methodologist as we had with Stavros Antonio, it wouldn't have been possible. Just as an example, you see here how it works. The introducing all the papers selected in evaluating the study design, the risk of bias, the inconsistency. I will not read all the lines, but you can understand how complex. And of course, we had a systematic review of the literature in this interval of 14 years, using, of course, a professional librarian from the VU in the Netherlands, Hans Kett. We thank him for the great job he did. And the criteria for searches are listed here. Because we had to deal with more than 20,000 papers in this time frame. So it's been really a tough work in selecting this. And we also had exclusion criteria. We thought that because of all over the world, bariatric surgery is laparoscopic surgery. In Italy, it's 99%, in the other countries as well. So we thought that we had to exclude the open surgery and also the techniques which are now obsolete. Just as an example, the vertical gastroplasty, which was very used in the 90s. Now it's almost abandoned, no sense to include that. And then we also excluded some side topics, I could call them. Modified laparoscopic approach, balloons, because balloons are a medical treatment, new technologies which do not have yet evidence in the field of bariatrics, and pure metabolic surgery, which is an interesting field, but it's not our main topic, which is bariatric surgery, because losing the obesity parameter will make things much more complex. Systematic review, you see here listed the kind of papers we looked at, meta-analysis of RCTs, core studies, individual RCTs on core studies, addressing the same frameworks to those of the questions we predefined for adult patients with a BMI over 35. And I come again to the point of the tandem. This has been also an educational activity because the juniors which had cooperated with their own senior scientists did a great job and learned a lot about the methodology. And two of them now are members of the research committee of EAES. This means that they developed a competency which will be used in the future in many, many other activities. Similar. This is another picture of the group with a lot of young people. These guidelines may and must be used, we could say, by healthcare professionals, of course, but also as a reference for policymakers in Europe, but not only in Europe, and are valid according to the agreed concept till December 2024. This means that they will be updated not far from today, because 3 or 4 years is not a long time, and the work takes 18 months. The system of PICO question is very well known. I will not go in details. It's always based on comparison among an intervention and a comparator. This is important to understand the future study. These are the 7 topics which are those we deal with in our clinical practice, from indication to investigational and post-operative care, and also some investigational procedures. I will not read all the slides. This one and the next one, which is including the specialists, we thought that the medical part would be much better for the preoperative, for the follow-up, and for these parts. While the surgical group made mainly by the EAES and IFSO-EC people developed the part which was related to the procedures, BPD, Roux-en-Y, and so on, as you see in the slide. Prisma, like in all this work, to get to the final group of papers which were included in the review. The final achievement we had was that after the selection and evaluation, we reached the point where recommendations could be issued, and they can be classified as strong for the intervention or the comparator, conditional for the intervention or the comparator, of no recommendation. In this case, we decided, as it is for the rule, to have the option to draft a position statement. And finally, we had 36 recommendations and position statements that we will see in a while in these three different classifications. Then we had a Delphi process, 3 rounds among the group to reach a 75% of agreement for all recommendation and position statements. And then we had a survey among the members of the participating societies to investigate the applicability, because this is also important very much in the practice, because we can have wonderful guidelines, but if they are not applicable, it's a waste of time and no sense. And then in 2019, at the Sevilla conference of EAES, we had an on-site survey using the smartphone and the systems, usual systems that are now used in this dedicated session. A picture coming from exactly that session, a single slide to show how the survey was run. This is standard, I would say. And finally, the appraisal, the full guidelines in its final version, was reviewed by the president and president-elect and also editor-in-chief of obesity surgery. So this was the final evaluation of the papers. We are satisfied about the paper. We can also always do better, but this is what we achieved. Now we move to the topics. This is number 1 question, preference of bariatric versus non-surgical management. And we have a strong recommendation for patients over 40 or for patients over 30, 35 with metabolic problems, with some associated metabolic conditions. This is the algorithm. I will not go in details, just to let you understand that we also had a graphical representation of our results. Preoperative workup, different specialties. H. pylori eradication versus standard care. Diet consultation versus standard care. Recommendation, conditional for eradication of H. pylori. Strong for dietitian consultation, which has been changed from conditional to strong, according also to the opinion of the representative of the patients that were also involved, and they thought that using the dietitian consultation was a cornerstone, and we decided, according to this suggestion, to change the recommendation to strong. Preoperative endoscopy, hot topic, and psychological condition assessment, preoperative always. Conditional recommendation for both, for the endoscopy as a routine test and for the psychological evaluation. And this is related to the lack of good papers in regard. It seems strange, but it is. And because of binge eating and depression are very frequent, it was clear that they may not be considered an absolute contraindication. Graphical representation, recommended and recommended dots or lines. You see, we're not going to tell you, will find all these documents in the paper. Perioperative management. Sleep apnea screening in all patients. CPAP in patients preoperative. Dose of antithrombotic prophylaxis. Conditional recommendation for the screening using the stop bank criteria, which is a simple system, can be very useful. Strong recommendation for CPAP in patients with severe obstructive sleep apnea. Conditional recommendation, because about the dose, we couldn't give any recommendation for the dose and duration of vena cava filters. ERAS, another hot topic, ERAS protocol, and a kind of analgesia after the surgery. Strong recommendation for avoiding using the vena cava filter because of complication. Conditional recommendation for ERAS because there is not enough evidence, not because the concept is wrong, not because the concept is not good. Many of us and more are using this protocol, but it's not yet demonstrated the advantage in the long run. And conditional recommendation for using opioids in the postoperative. Again, you see here the graphical part, the algorithm. We now get to the different bariatric procedure. For each procedure, we had a different group. Band, can it be used considering the side effects? A position statement, because of the high rate of reoperation for an insufficient weight loss. This is all what we get from the literature. Not enough for a recommendation. Sleeve gastrectomy. Sleeve versus band, sleeve versus placation. Conditional recommendation to prefer the sleeve to the band for weight loss and metabolic condition. Position statement for sleeve versus placation. This is because of the lack of literature. Only difference in the midterm results, no long-term comparative data. This is why we couldn't have any recommendation issued. Sleeve gastrectomy with kind of antral resection, kind of Bouvy, staple line reinforcement. All these are hot topics in the field of sleeve gastrectomy. We had a position statement for the antral resection, which recommendation conditional for the Bouvy, and the staple line reinforcement should be considered. I wish to stress that it is only related to the complication of bleeding. This is the only evidence we had. We couldn't split the topic, but it's because of hemorrhage. Roux-en-Y versus placation versus band. Position statement versus gastric placation for the same reasons of before, lack of long-term results. Roux-en-Y versus band, strong recommendation. This is evident in the literature. Roux-en-Y versus sleeve for weight loss, and subgroup analysis of patients with reflux. And we have a position statement, Roux-en-Y versus sleeve, although now a couple of papers came out with some different data, but not yet enough to change this data, this concept. And Roux-en-Y preferred to sleeve gastrectomy in patients with severe GERD or severe esophagitis. The algorithm. BPD-DS, this is the story of bariatric surgery, so it was included, although not many procedures are performed. BPD-DS versus other procedures. And there is a position statement, BPD versus Roux-en-Y superior for metabolic reasons with a lack of data, and conditional recommendation, BPD or sleeve can be made on the basis of available data, but we have a very scary literature in this field. One anastomosis, the rising star. One anastomosis versus the other procedures, SADIS versus the other procedures. Position statement, one anastomosis may offer better short-term weight loss, but we don't have long-term comparative data. SADIS, recommendation conditional, because no recommendation can come from this comparison. Then we come to revisional surgery, which is a difficult topic. So we decided to, first of all, to define what we are talking about. So we have speak about patients who are primary non-responders, insufficient weight loss, or secondary non-responders with a weight regain. And should we use revisional for failed bariatric surgery? No way to have data from the literature, so we no evidence-based criteria for indication to revisional, but we strongly suggest that all the patients with the weight regain should undergo a complete multidisciplinary assessment, as for the primary procedure. Postoperative care as well. Schedule follow-up. Ursodeoxycholic acid to prevent gallstone disease in the postoperative time, and nutritional supplementation. And we have strong recommendation for postoperative follow-up, conditional recommendation for the use of the acid for prevention of gallstones, and a strong recommendation for the supplementation. This is very good. PPI in patients undergoing bariatric surgery. Diet versus standard care, delayed pregnancy, 3 different questions. and strong recommendation for PPIs for those who have a bypass, different kind of bypass. Conditional recommendation for nutritional and behavioral advice, and strong recommendation for delaying a pregnancy after a bariatric procedure. Again, graphical representation. We also evaluated some investigational procedures that you see listed here: sleeves, aspiration, stimulation, resurfacing, and endoluminal suturing. But while for the first ones we didn't have any evidence, we decided to have a position statement for endoluminal suturing procedures that may have a role in treatment of obese patients with a low BMI. This is the final paper, which was accepted in April and published on this issue in June. Going to the conclusion, we summarize the pertinent evidence in the field of bariatric surgery. Despite of the advancements in the field, we identified several gaps, but mainly in the lack of long-term reporting of outcomes. So we then encourage scientists to focus on reporting long-term results. Thank you for your attention.
Good morning, ladies and gentlemen. I'm Dr. Ha from Hanyang University. I would like to appreciate the president of KSELS and all the staff to give me the chance to present this presentation. Today I'm going to talk about animal experiment for bariatric surgery. First, I'd like to announce that I have no conflict of interest. My presentation consists of 4 contents. First, when and why I started the animal experiment. Second, what I have done with animal experiment. Thirdly, what I have learned from animal experiment. Lastly, what to expect from this animal experiment. Let's start with how I got involved in animal experiment. In 2007, while I was searching articles online, I discovered this article written by Dr. Rubino. Now he's one of the most famous scientists in terms of bariatric and metabolic surgery. But then I was both shocked and excited to have come across this animal research, which was unpopular at the time. In this article, he addressed the mechanism of diabetes control after gastrointestinal bypass surgery and insisted on the foregut theory. I was in my fellowship program at that time. My field of interest used to be gastric cancer. The surgical procedure between gastric cancer surgery and bariatric surgery are similar, but different. When it comes to below 2, the common procedure between these two surgeries is to bypass proximal intestine, duodenum, and part of jejunum. Some patients with gastric cancer already had diabetes before they underwent gastrectomy. I wonder if I could treat gastric cancer and diabetes at the same time performing gastrectomy with bariatric surgery. So I talked with one of my bosses about my idea. But He did not agree on my opinion. My idea was entirely hypothetical without evidence. Moreover, he put great emphasis on nutrition in gastric cancer. How could we ever perform this surgical procedure on gastric cancer patients, which result in malnutrition? So I decided to investigate my hypothesis, and this curiosity made me start animal research. I tried to learn about animal experiments and found out that animal research could uncover underlying physiological mechanism of bariatric surgery. It's because we can alter and modify technical experimental design using animal model. And I thought the effect of bariatric surgery on metabolic disease could be discovered. However, animal data of bariatric surgery were inconsistent and not comparable among previous animal research, so the standardization of animal model was necessary. In 2015, some researchers published the standard procedure of bariatric surgery in rats and mice in Nature Protocol, which is a high impact factor. In this article, the researchers suggest that the most and appropriate surgical model of bariatric surgery in rat and rodent with a high survival rate are like this. Figure A shows the Roux gastric bypass in rats and mice. Figure B shows sleeve gastrectomy model. This is perioperative care protocol. They had mice and rat on the fasting state for 3 days. I guess rodent should be forced to fast to avoid aspiration. Here are many pictures presenting actual surgical procedure. I think animal model of rat is quite easier than that of mice. This figure shows how to make sleeve gastrectomy in rat. They made the sleeve using Bouvy to prevent stomach from narrowing. This is another paper that reviewed the sleeve gastrectomy and wrong-eye gastric bypass surgical model in mice. They reported the surgical procedure can reduce surgical mortality. They reported that vertical sleeve gastrectomy with Lambert suture was the best procedure for sleeve gastrectomy. As for wrong-eye gastric bypass, making small gastric pouch for gastrojejunostomy had a low mortality rate and became the standard procedure for wrong-eye gastric bypass in animal model. They also note that even for experienced surgeon, at least 4 years of practice was required to reduce mortality rate in animal bariatric surgery. Now I'm going to tell you what I have done and how I have done my animal bariatric surgery, and what I have obtained the scientific result from my animal experiment. I used this rat when I set up bariatric animal model. ZDF rat is the best rodent for conducting diabetes animal study. These rats are quite expensive. They cost 500 pounds per one net. The rat beside is Vista rat. These rats are also widely used for studying obesity. This instrument are surgical tool when I used from the beginning of my animal research. I used 6 times loop. Here are many surgical instruments I recently bought. To make anastomosis in mice, I need a few delicate and fine instruments like vascular clamp and micro needle holder. This is a surgical clip, very fine suture material, size 8, 9, and 10. I prefer using ethylene suture material, which are easy to handle but quite expensive. This is a vascular clamp that I used when making anastomosis and checking the leakage in the anastomosis site. This is the animal operation model, the operation table. This is made in Korea. I think this table is great for animal surgery. You can control temperature during surgery and keep the animal warm. It also has a magnifying glass for assistant. This slide shows that the two surgical techniques. One is right gastric bypass on mouse, and the other is on rat. I'm making jejunostomy. Using 9 or 10 ethylene suture and check any leakage and freeing stomach around the organ and cut the esophagus and close distal stomach. So I'm making gastrojejunostomy and finally check any leakage and close the abdominal wall. This video clip is right gastric bypass procedure in rat. Compared to mouse, the right gastric bypass in rat is easier. Now I'm making jejunostomy. I usually use the 7 or 8 ethylene suture in making jejunostomy, and I'm doing dissect around the stomach and cut the esophagus. And making gastrojejunostomy. This is the most important procedure in right gastric bypass and close abdominal wall. This is my boss when I spent my sabbatical year in Ireland. He's one of the most famous scientists in the field of bariatric surgery. He is not a surgeon, but a clinical pathologist. The first article from my animal research was published in 2014. I made a duodenojejunal bypass model and investigated the effect of bypass on glucose metabolism. This study revealed that intestinal gluconeogenesis increased in duodenojejunal bypass group through the increased glucose transporter. The next research was an animal study using sleeve gastrectomy. We reported that the sleeve gastrectomy suppressed hepatic glucose production by the decrease of gluconeogenesis pathway. I wonder if gastrectomy in patients with gastric cancer could have effect on metabolic disease. So I have conducted clinical research to investigate the effect of gastrectomy on cardiovascular risk factor and lipid profile, and found out that gastrectomy in gastric cancer patients could reduce cardiovascular risk factor by changing lipid profile, such as HDL, LDL, and triglyceride. From this result, I made the hypothesis that gastric surgery involving gastrectomy or bypass procedure could prolong human life. I thought bypass surgery has a more potential impact than controlling glucose level on obesity. It's related to longevity. As you know, bariatric surgery reduces cardiovascular risk and improves survival rate. Most people think that patients had bariatric surgery can live longer because they eat less, lose weight, which can cause the reduction of cardiovascular risk. However, I guess there are another mechanisms that are not discovered. Some genetic factors enables humans to live longer than expected. Sirtuin was discovered and verified a few years ago in Nature journal. We tried to find out whether this gene is also related to longevity in animals. We demonstrate that bypass surgery stimulates an expression of certain gene. So I hypothesized that patients with bariatric surgery could live longer than expected as a result of certain gene expression. Now I'm moving on to what I have learned from animal experiments. These are the results from bariatric surgery on rats and mice. From July 2019 to June 2020, we conducted bariatric surgery on total 65 rats and 25 mice. Out of 44 bypass rats, 25 rats survived. But only 2 mice have survived out of 20 bypassed mice. Most of the experimented mice were dead during or after the surgery, so we decided not to conduct duodenojejunal and gastrojejunal bypass surgery on mice. Next, I would like to share the complication that appeared in our experiment. Before the surgery, we used to fast the rodent more than a day before the surgery for better outcome. However, we later found out the animal ate their own hair, even their own tail, after massive fasting. The hair in the stomach blocked the GI tract, and some rodent result in aspiration was probably dead due to respiratory failure right after the operation, so decided to give fluid diet until a day before the surgery to avoid this complication. Next, I will talk about anesthesia during the surgery. In the beginning part of our animal experiment, only few rat and mice survived, even when the surgery was done flawlessly. In July 2019, only three rats out of 16 survived from the bariatric operation. After the surgery, most of the rats had problem in moving their hind leg, which I show you in the next slide, and only moved with their front leg. It seemed like half of their lower extremity were paralyzed due to some kind of neurologic injury. If it wasn't because of the surgery, we thought it resulted from anesthesia, so we changed to intraperitoneal anesthesia, and all three rat intraperitoneal anesthesia survived. In the beginning of the surgery, we used both inhalation gas, nitrous oxide, and oxygen along with the isoflurane. But most of the rats were dead after or during the surgery, so we tried to find out the cause of death. We searched the article online and found out the prolonged exposure to inhalational anesthetic nitrous oxide kill neuron in adult left brain. And combining nitrous oxide with carbon dioxide decreased the time to loss of consciousness during euthanasia in mice. So we thought the cause of death was nitrous oxide. So we use only oxygen along with the isoflurane. I will show you the video clip, the effect of nitrous oxide. The rat could not move their hind leg. Seems like she is paralyzed. And more rats survived. After solving the mystery of anesthesia on rodent, improving early post-operative death, but still many animals died even after 3 weeks. From autopsy, we found the death result from bleeding or bowel preparation. But in some autopsy, there is no specific finding in bowel. So we consider death was probably due to aspiration, dehydration, infection, and low metabolism rate due to loss of appetite. and low food intake. From the experience, I learned that animal research is the bridge between surgeon and researchers. And I learned many skills through the animal surgery, especially microsurgery, and the research can also allow me to have global partnership with many famous scientists. To conclude with my expectation in the future with animal research, I'm going to keep doing animal research to uncover the mechanism of bariatric and metabolic surgery. There's still prejudice against bariatric surgery in Korea. I would try to change their perception by providing clinical benefit of bariatric surgery. I hope my effort provide enhancement in welfare of many obese patients in Korea and also worldwide. Thank you very much.
Good morning, everyone. Thank organizers for inviting me this session. Today, I'm going to talk about a research topic regarding the metabolic surgery. When it comes to today's topic, I think the issues regarding the metabolic surgery is a little too much broad to be covered at once. So I'd like to take a subject and briefly touch it in a short talk, which is about what's the accurate predictor for diabetes remission after surgery will be. How to select a patient who will be adequately enjoying good glycemia control is an everlasting question. At least so far, we can see complete remission of diabetes not infrequently in the practice. However, the miracle does not always happen to every patient. So finding a novel potential predictor is vital and should be on the cutting edge beside conventional clinical scoring system. I believe that valuable predictors for surgical outcomes will be able to optimize surgical criteria followed by maximum beneficial anti-diabetes outcome. There are several potential factors we need to go over. Other than known factors, it can be categorized first of all biological molecules relating to energy metabolism and the factors affecting systemic inflammation and genetic disposition per se. I'm going to start with the biological molecules involved in energy metabolism. First parameter in this category under research is the serum stearic and palmitic acid ratio. Previous studies show that free fatty acid product to precursor ratios can be used to estimate elongate and desaturate activities and association of their altered activity with the worsening of glycemia and incidence of type 2 diabetes. In this heat map, we can recognize somewhat unique characteristics of product to precursor ratio in diabetes patient. Among the 24 individual ratios of free fatty acid, some are found to close associated with the metabolic status of obese individuals. In the right pane, among them, the serum aspirate ratio is lower in the diabetes group preoperatively. Here we have a question. If there is any difference in the ratios between a remission and non-remission group, yes, there is. Preoperative aspirate ratio is higher in the remission group, and that may be because the serum palmitic acid level is relatively low. Effect of the cutoff value of 2.1, the aspirate ratio is significantly additive. When it is combined with duration, A1C, and C-peptide, area under the curve of ROC curve can be increased to 0.93. That makes sense because palmitic acid is notorious for its role on insulin resistance. I think it is clinically valuable for the prediction of diabetes remission in a clinical setting, at least in part in the diabetic patient with high BMI. Another potential predictor in the same category is quinodeoxycholic acid. This idea was conceived because the bile acid acts as a hormone, and they are involved in the modification of metabolic homeostasis. CDCA is reported to be the most potent endogenous ligand for FXR and can induce activation of TGR5 and release gut peptides and directly affect beta cell function. The preoperative proportion of various types of individual bile acid relative to total bile acid are different each other between remission and non-remission groups after randomized gastric bypass. Remission groups seem to have higher preoperative CDCA levels, and it is remarkably decreased postoperatively. CDCA percent has a good performance in predicting remission comparable to conventional factors. The area under the curve of ROC was 0.77, slightly higher than C-peptide and even hemoglobin A1C. Fortunately, CDCA had additive value as another prognostic marker when applied to the patient underwent randomized gastric bypass. We already know that ingestion of CDCA during the OGTT suppress insulin resistance, so we can say that the post-bypass surgery lowers the relative fraction of CDCA via the unknown mechanism and induce better glycemia. The other research target is succinate. We already understood that the succinate serves as an intermediate in multiple metabolic pathways. In this regard, determining the potential use of baseline circulating succinate to predict type 2 diabetes remission after metabolic surgery is worth trying. After 3 types of surgeries were applied to the patient with the same level of baseline succinate, the average serum concentration dropped down 1 year postoperatively, and it mainly happened after randomized gastric bypass. Among 3 cohorts according to the procedures, the bypass surgery dominantly improves type 2 diabetes as early as 1 year and then after. Regardless of the preoperative succinate level, the green represents the patient achieving complete diabetes remission. 2 years after surgery, almost half of the patients achieved the remission, mainly through the randomized gastric bypass and partly through the sleeve gastrectomy and publication. The preoperative succinate level is positively associated with glucose, A1C, and TG level. Baseline serum succinate was significantly lower in patients with the complete remission. In the left pane, we can see that the cutoff value of 48 millimole shows very nice predictive performance for remission with 91% of sensitivity and 50% of specificity. Even it can be reproduced in the validation code. If we combine it with the DIRM score system, the diasuccinate score dramatically improved its prediction performance. The performance prevailed the DIRM alone, and it was better than the DIRM and ABC score as well. Also, overall, we can see the possibility that the preoperative level of circulating succinate is an independent predictor of type 2 diabetes remission after bariatric surgery. What if we divide the fate of remission according to the cutoff value? Favorable low succinate level and less favorable high succinate level. The preoperative favorable level of succinate seems like successfully correlate with the complete remission. Most interestingly, bypass still works much better even in the patient with the less favorable level. However, interestingly, sleeve gastrectomy failed to overcome less favorable characteristics. I guess it'd be better to choose a Roux-en-Y gastric bypass to maximize the remission rate in case of a patient who has less favorable succinate level. I think a noble potential predictor might help a surgeon to select an appropriate surgical options as well. Some other potential predictors can be categorized into biological molecules relating to systemic inflammation. Those in these mediators not only associated with inflammatory reaction, but beta cell apoptosis and insulin resistance. The first one we're going over is osteopontin. Osteopontin is one of the multiplayer transmembrane signaling protein involving everywhere, mainly as an inflammatory molecule. The baseline serum osteopontin level was twice as high in patients who had remission 3 years after Roux-en-Y gastric bypass. The preoperative level of osteopontin acts independently of other clinical parameters such as age and the duration. Osteopontin showed a good performance value to distinguish remission from non-remission. However, still we need to figure out why higher preoperative level of this non-specific inflammatory factor is associated with much more chance to remission. Possibly, as a high open osteopontin levels in type 2 diabetes patient might reflect more baseline inflammation, or it could be considered as an innocent bystander biomarker. Recently, a very simple but interesting research result came out. The cutoff value of 1.97 of neutrophil to lymphocyte ratio has a good performance. Unique feature of this investigation is that even 5 years of long-term follow-up, the discrimination power maintained nicely. We don't have to disregard the usefulness of this very simple laboratory test, and we need to validate in a larger cohort. To finalize going over the novel anti-diabetic predictors, I'm going to move on to the genetic predisposition that contribute to metabolic derangement. The genetic predisposition of individual gene may correlate with diabetes beneficially or deleteriously. In reality, we have currently identified more than 80 SNPs affecting glucose metabolism. Genetic predisposition can be assessed by selecting the SNPs associated with the susceptibility to diabetes, obesity, appetite regulation, and the response to bariatric surgery. The selected SNPs were grouped by 3 genetic predisposition risk, then the scores were calculated based on the total number of risk alleles. Certain cutoff value shows good performance to predict remission, even better if they are combined with diarrhea. Surprisingly, this genetic predisposition also seems to have a prediction capacity of the relapse 5 years after the primary remission. In summary, the research should be prioritized. The investigation of the novel predictors for anti-diabetic outcomes after metabolic surgery. It is critical to optimize the patient selection criteria and the selection of an appropriate procedure. That's all for today's topic. And thank you attendees for your attention.
I think there are only 5 minutes left for a very quick conversation at the end. I would like to start by addressing just one question to the first two speakers, each one of the first two speakers. So the first one is Professor Bouvy again. And I would like to ask about the Apollo endostitch, which seems to be the most popular way for performing So, in your opinion, Nicole, which one are the most suitable candidate for this type of Apollo endostitch, which seems to be the most popular way for performing So, in your opinion, Nicole, which one are the most suitable candidate for this type of endostitch, which seems to be the most popular
Okay.
way for
So there's if you have a patient with a BMI of
which one are the most suitable candidates
in between 30 and 35 who is a volume eater and doesn't
May I
suffer
ask all the others please to mute yourself, just leave the one who's speaking unmuted, otherwise we have echoes. Thank you.
between 30 and 35 who is a volume eater and doesn't
May I
suffer
ask all the others please to mute yourself, just leave the one who's speaking unmuted, otherwise we have echoes. Thank you.
between 30 and 35 who is a volume eater and doesn't
May I
suffer.
ask all the others please to mute yourself,
There's a lot of echo.
otherwise we have echoes. Thank you. Nicole, perhaps it's you. You need to close the other platform.
Okay. Is this better? This is probably better now. Eh? Okay. So if you have a patient with a BMI of in between 30 35 who is a volume eater, suffers from a bit of GERD, and doesn't suffer from diabetes, then probably this is the right patient to have an Apollo endostitch or a post procedure. What we see, especially in contrast to the sleeve resection, that you can help people with GERD to have less GERD after these endoscopic endoluminal procedures than after, for example, a sleeve resection.
Sorry. Well, thank you very much. Nicola, very quickly, I would like you to comment on the disappointing result of the survey in terms of lack of evidence to drive us in making the right decision. Is there anything we can do about that?
Thank you for the question, Andrea. And as I pointed out, it's very important. It's a critical issue. We have 21,000 papers screened, so many reports on short-term results, middle-term, but a total lack of results in the long term. And as you know, bariatric surgery is a lifelong procedure in terms of results. We expect to change the life of people, and if we don't have enough data, this is really a problem. I think this is something to be stressed in all the international societies to get a better result. It takes long, of course, to follow up these patients, but I think it's the only way to measure things in the appropriate way. And again, if you use the appropriate methodology, this is so evident. Some procedures are now obsolete, so you cannot continue to evaluate them, but some of them are very popular, so it shouldn't be so difficult to have these results, but this is the truth.
Okay, Professor Park, it's up to you.
Yeah.
Continue short.
Okay, for 23, we have the break time after this session, so we have a little more time to discuss. As I have a question for Professor Ha, as the experimental animal should be as similar as possible to human being to apply the good result. And so my question is really based maybe a stupid questions, but have you ever tried experiment using large animal rather than rodents? Is there any reason why there is the mice used in experiment for the bariatric surgery?
Unfortunately, I haven't had any experience with large animal than rodent, but if I have chance, I'd like to do. But as you know, the rodent, especially rat and mouse, is quite similar to human. So I'd like to give you more information. The mouse has gallbladder, but rat.
Professor Hara, please little close to the mic. Yeah.
So
yeah.
For your question, I have no had any experience large animal performing the bariatric surgery except the mouse or rat. And I'd like to give information to researchers who would like to do the bariatric surgery in rodents. The mouse and rat is quite similar, but it's some difference because the mouse has a gallbladder, but rat doesn't have. Because the bile acid is quite important for revealing mechanism of remission of diabetes.
Yes, thank you for your very interesting topic. Yeah, Professor An.
Yes, I'm here.
Yes. Do you have any more comment for your presentation?
Yes, I'm. First of all, I'm very sorry about the very, very short talk, but as I told you something about the broad spectrum of hot topics in this field, so that's why I take just one topic here. But anyway, I'm focused very currently. I have been very focused just in the succinate level. As I told you, the succinate level is a strong multiplayer in the metabolic mechanism in the human body. So if we can validate this kind of good result in the different cohort, we can add very strong predictive markers into the already popularized clinical scoring system. Yeah. That's all. Yeah.
Yes. Thank you. And because there is no questions from the participants, is there? Do you have any questions, Professor Pietrabissa and Professor Bouvy?
I will take I'll take just simple question to Professor Nicola. Do you have any either about the deep vein thrombosis thing during the Delphi discussion of making this new guidelines?
Thank you for the question. It's a very good one. We didn't evaluate this part because in the PICO questions, we decided to shift to switch to more general questions. But this is an evident thing coming with the introduction of the sleeve gastrectomy, the introduction of the venous circulation in that area, and the report is growing more and more. EAES has produced a survey which will be published in the next months about this event. So I'm happy to give you an answer in a few months.
Thank you so much.
Thank you for the question again.
Thank you, everyone. And so this is all we have time for our Q&A time. So thank you for your attention and participation of our speakers and chair. And thank you very much.
Thank you very much.
Yeah, yes.
Successful meeting.
Thank you.
For joining.
Yes.
Very nice meeting.
Thank you for joining.
And I introduced the next session. Next session in this channel, Symposium 5 will begin from 10:10 in Korean times after 20-minute break and the opening ceremony. Yes. And see you in the next session in this channel. Thank you. Thank you, everyone.